Welcome our next speaker, our superwoman, Professor Louise Emmett. She's going to tell us some more trial updates, but using lutetium PSMA in the earlier setting. So thank you, Louise.
I am. So thank you very much for asking me to talk again. And I'm going to talk about moving theranostics earlier in prostate cancer, but really focusing on moving PSMA theranostics early in prostate cancer. And I'm sorry, everyone, I do have some overlap between yours and my slides. I also have some overlap because I'm using Michael's lovely slide, giving us the therapy and vision trial designs. And we have these two great randomized trials which show that lutetium PSMA 617 is effective post-chemotherapy in the mCRPC space. So we know from the vision trial that we've got improved overall survival compared to standard of care, excluding chemotherapy, and with the therapy trial, we've got equivalent overall survival to a second-line chemotherapy agent, but with much improved health-related quality of life. So why move it earlier? Well, we know from lots of trials, and including these trials, that there's increased lineage plasticity and clonal heterogeneity later in the disease process. So these cancers escape treatment control much earlier. Most treatments are much more effective if we move them earlier, and we get improved overall survival. We can actually avoid morbidity in these patients by keeping the disease volume low, using effective treatments earlier. We have less pain, we have less fatigue, and we have better quality of life. And if you're being really, really optimistic, if we move potential effective therapies pre-ADT, we can potentially avoid metabolic effects of long-term testosterone suppression. So we'll see how we go with that one. But there are problems with moving PSMA theranostics earlier in the space. We have lower PSMA expression in hormone-sensitive prostate cancer in many patients, and that has the potential to cause reduced PSMA therapeutic effect. How intense should the target be in early-stage disease for us to get an effect? It's not something that we actually know at the moment. And if we're adding PRRT or PSMA targeted therapy to ARPI and ADT in the hormone-sensitive space, we may actually have more limited target. We know from a number of PSMA PET studies that about 80% of patients who have ADT and ARPI in the hormone-sensitive space actually lose their target, sometimes entirely. So if we're going to add PSMA targeted therapy to that, we need to be very careful how we add it. We may need to do adaptive dosing. We need to use biomarker guidance in the hormone-sensitive space even more than we do in the metastatic space, castrate-resistant space, to get better treatments responses. And we're competing with systemic treatments early on, which have continuous receptor impact. So if you're on an ARPI like enzalutamide, darolutamide, apalutamide, that's a daily tablet. That receptor is controlled on a daily basis. With PSMA-targeted radionuclide therapy, we only get a few hits. If these patients are going to have disease control for a few years, how do we use our treatments to value add in that space? It's something we have to think about very carefully. We also need to think about the potential longer-term toxicity. Most of the patients that we've treated up till now have actually died of their prostate cancer pretty early. So do we get myelodysplasia? Do we get kidney dysfunction? Do we have other longer-term toxicities that we need to know about? So we need to be really smart in how we implement this treatment earlier to maximize effect and minimize toxicity. And I think we have all the tools, and I wouldn't call these problems, I would call them issues that we need to think about carefully and to address in prospective trials. So let's start with moving one step down the ladder, moving pre-chemotherapy in the mCRPC space. So that's PSMA4. So that's a study that also read out at ESMO last year. PSMA4 is a large randomized phase 3 trial, and it's essentially randomized 1-to-1. It's patients who have failed an ARSI in the hormone-sensitive setting, and they get randomized to either a second-line ARPI or they get randomized to lutetium PSMA 617. So RPFS was the primary endpoint. There were 234 patients randomized to each arm. And at the primary endpoint, at RPFS, the patients on the standard of care arm were allowed to cross over to receive 6 doses of lutetium PSMA 6 weekly, and 84% of those patients elected to do so. The primary endpoint, rPFS, was strongly positive, and patients on the lutetium PSMA-617 arm had a median rPFS of 12 months versus 6 months if it was an ARPI change. But the problem comes around with the overall survival. So if you're going to get regulatory approval to move pre-chemotherapy, I think the governments or need to show that at least overall survival is not impacted. And at the moment, the overall survival, or the hazard ratio for overall survival, crosses 1. Now, this is a very early interim analysis for overall survival. There are more analyses for overall survival coming up in PSMA-4. Hopefully, they're getting lower, below 1, so that we can get funding for lutetium PSMA-617 pre-chemotherapy rather than the vision space. That would be amazing for our patients. So ENZA-P is another trial that is also in the early mCRPC space, and Arun has touched on that. It's an ANZUP-sponsored trial run at 15 centres around Australia. It had a slightly different approach. It's patients who were early mCRPC going on to first-line enzalutamide, and they were randomised between first-line enzalutamide versus first-line enzalutamide plus 2 or 4 doses of lutetium PSMA. In this setting, the idea was to use PSMA as the adjunct treatment, not as the primary treatment, so 2 effective treatments together. This study was also positive with a progression-free survival endpoint of 7.8 months for enzalutamide and 13 months for enzalutamide plus lutetium PSMA. With rPFS, the progression-free survival was 12 versus 16 months. And we got much deeper responses from PSA as well with the combination. So PSA 50% response rate was 68% with enzalutamide versus 93% with the control, and 90% PSA response rates were 37% with enzalutamide versus 78% with the control. And I'll just point out, in fact, because we had 2 patients who didn't get treated on the combination arm, it's actually 95% and 80% if you exclude the patients who didn't get treated. So very, very deep responses. So let's move even earlier to the hormone-sensitive space. This takes us to PSM addition. So PSM addition is a very large trial, and it'll probably need to be. It's 1,126 patients. It's patients with newly diagnosed hormone-sensitive prostate cancer, either synchronous or metachronous. They're going on to standard of care, which is ADT and an ARPI, and they get randomised to standard of care, ADT and ARPI, or ADT, ARPI, and 6 doses of lutetium PSMA-617 continuously. This is very similar to PSMA-4. rPFS is the primary endpoint, and they also are allowed to cross over once they reach the primary endpoint. So potentially this study will have the same problem as PSMA-4 with overall survival, and it'll be reading out this year, I think. Arun and Michael are running the upfront PSMA study, which is also, as Arun said, going to read out this year, which is combination of docetaxel with 2 doses of lutetium PSMA in the hormone-sensitive setting compared to docetaxel alone with undetectable PSA at 12 months as the primary endpoint. So what about if we can actually avoid ADT entirely? Sort of, this is the holy grail. It's what a lot of men who have metastatic prostate cancer really want us to do. So it's a busy space. These are all the oligometastatic trials that are opening up in this space. They're using SBRT plus lutetium PSMA of some form. Some of them are actually antibodies. And I just want to point out ProsTIC24, which is being run by Shankar Siva and Aravind Ravikumar. We had the SIV finally in Sydney for this. So this will be opening. It's being run by Peter McCallum. And it is SBRT to less than 4 sites, pre-ADT, plus 2 doses of lutetium PSMA added in pre and post the SBRT with progression-free survival as the primary endpoint. So super interesting to see whether we can actually make an impact in this space. And once again, it's the intensity of the activity that's going to cause problems for us. So moving really, really, really early is the study that was also done by Peter McCallum and has now been published, the lutectomy trial, super cute trial of lutetium PSMA, 2 doses prior to radical prostatectomy in patients with high-risk disease. A very experimental trial that's now been published in European Urology with Reinu Epen as the first author, Michael Hoffman as the last author, 20 patients. They had to have an Smax of greater than 20, and the PSA 50% response rate in these patients was 45%. Primary endpoint was actually absorbed dose, which was 35 gray, And there's an extensive translational program which is part of Renu's PhD, which will be super interesting to watch. If we're talking about holy grails of holy grails, then this is it. This is the NEPI trial. So NEPI trial is being run in Essen with Ken Herman's group and Boris Hadashek. And it's the idea of using the DNA damage from PSMA-targeted radiotherapy to highlight to the immune system that the prostate cancer is present. The problem with prostate cancer, it's often immune suppressive. So can we actually say to the immune system, this is here, treat it and actually reduce biochemical recurrences? So this very brave trial is giving 2 doses of ipilimumab plus 2 doses of lutetium PSMA prior to radical prostatectomy, compared to lutetium PSMA alone. And so in conclusion, I think moving treatment earlier, particularly pre-chemotherapy, is super important. We know it's better tolerated than chemotherapy, but we do need to confirm improved overall survival, I think, before we get regulatory approval in that space. We need to ensure additive benefit when combining with other agents. And we really need to define where it should fit. Should it fit early? Should it fit in the hormone-sensitive space, or does it need to stay in the metastatic castrate-resistant space, just based on intensity of PSMA expression? Thank you.